All right. Good morning. Hello, everybody. Welcome to the Prescribing the Future podcast, where we explore how technology is transforming the way care is delivered. I'm your host, Dr. Jean-Luc Neptune. My friends call me JL, and I am the Executive Medical Director at Commure. Today, we're very fortunate to be joined by my friend, Dr. Dev Roy, who is the Chief Medical Officer at Nathan Littauer Hospital. And today, we'll be talking about what it's like to be a doctor, and we'll be talking a lot about rural care. But before we start, I wanted to give Dr. Roy a chance to introduce himself and just talk a little bit about his background.
Yeah, no, thank you, JL. This is just awesome to be here. Yep, I'm Dev Roy. I'm a hospitalist as well as a post-acute care physician. So I practice both in a hospital setting, in a nursing home setting. I also am a palliative care doctor, and so I'm always on. I also do some direct primary care, but in addition to clinical practice, I also am currently the CMO, CMIO, and VPMA at Nathan Littauer Hospital, which is a hospital, nursing home, and we also have 11 primary care specialty sites just kind of speckled in upstate New York. Also, there's a hospice here, so I'm on the board there. And there's a joint venture that I'm a president of that's trying to actually preserve care in a rural setting. So definitely wear a lot of hats, which is what we have to do in rural medicine, but I love it. It keeps me engaged. So
All right, so that's really interesting. It sounds like you're doing a lot of different things, and I'm always impressed by docs who are, who are practicing in a variety of different settings because, in many ways, it takes a lot of skill to be able to do that. But I think you also get to see a lot of interesting things, so that's really great. I think maybe a place that I wanted to start is, Nathan Littauer is not that far from Albany, right? So we think about Albany as, the capital of New York State. I'm doing this call from the Upper West Side of Manhattan, so I don't necessarily think about Albany as being rural. So describe to me what rural means, given that you're not so far from the state capital.
yeah, no, absolutely. So we're about an hour and 15, hour and 20 minutes about from Albany. And actually, I live in the Albany area too, in a place called Niskayuna. When it comes to rural here, so there isn't a lot of healthcare um, places that a patient here can go to, right? So, fairly a largely rural and aging population, and we go all the way up to Canada, and I think when we go west of us, the closest place is Utica. South is I believe Albany, St. Mary. So it's a very large area, and I guess in this rural area, not only do we have an aging population, but we have three ARCs. So folks that are neurodivergent or folks that have cognitive delay that have made it into adulthood with very rare illness. That's who we take care of. We have, I think, 3 or 4 nursing homes in our area, so just a very large area. Now it's interesting. So Gloversville, that's where our hospital is located. It actually got the name of Gloversville because all the leather gloves were actually made here, and so you had a very just a great working population here. But as the economics of making leather moved to other locations, then there was definitely a change of industry here, and that always leaves a huge gap in income levels. So you do have a very wealthy population here, but also a very poverty-stricken population too. So definitely get that huge variety of people that we take care of.
That's fascinating. And just thinking about, again, this geographic spread and, I'll ask you in a sec, or let me make a comment and then I'd love to get an answer to a question. But you have this broad geographic spread. You have this large spread in affluence, which I think, again, just makes it really challenging because so many businesses, right, are able to target and segment a specific customer, whereas you guys have to take so many different types of people and be able to support them. The question I was going to ask is, if you had to tell me, what's the average time that somebody would take to drive to Nathan Littauer? Like what is do you guys even calculate that? How long does it take to get to the hospital?
Well, absolutely. So it depends on the location, right? So for Gloversville, I mean, we're right in there 2 minutes, right? But for some of our patients, it takes about an hour and a half to 2 hours just to get here. Now it's smaller roads, it's weather conditions. There's a lot of things. Just now, we got hit with a lot of snow just yesterday, right? And our infrastructure in a rural area is not. It's not the greatest. So just a little bit of wind might destroy the power lines, which will just shut out electricity. Another challenge, I think, a couple of months ago, we just lost power because a squirrel bit a power line that went to an, right? It's like stories that you hear of, but they're legit things here. So I think when it comes to just pure distance for patients to come here, that's definitely a challenge. And does everyone have a car? Getting an Uber is not something that we can always do here, right? And so transportation, distance, these are always challenges. And so when a patient actually comes to us, because it's hard for them to seek care, we're seeing them when it's already fairly advanced disease. We don't have the army of subspecialists, for instance, or the tertiary care centers here. So it's definitely unique, definitely a challenge because we're not only the safety net, but we're trying to be a specialty hub. And yeah, definitely a challenge.
Got it. Interesting. And what would you say, what's the pay mix, payer mix? Does commercial play a big role, or is it mostly Medicare, Medicaid? Like what does the payer mix look like?
So primarily Medicare, Medicaid. I think we are. I think there's only two Medicare, Medicaid hospitals in all of New York, and we are definitely one of them. So I think 60 to 70% of our payer mix is Medicare, Medicaid. Then we do have some CDPHP, we have some United Health, just kind of speckled, but primarily it's Medicare and Medicaid. And as we're seeing the Advantage programs coming in, that's definitely been a challenge because they only pay for certain things. So that payer mix is definite. It makes it harder and harder to practice as reimbursements is always going down.
Got it. Understood. So we have challenges of patients getting to the practice. You have the challenge of the payer mix not being advantageous. You mentioned you didn't have a lot of specialists. Any other big pressing challenges that you guys see, like maybe from a leadership perspective, that you identify as top challenges that you're trying to address?
No, absolutely. So when it comes to, we mentioned costs in general in healthcare is going up, right? I mean, with AI coming out there, right that's going to take a lot of cost for companies to create, right? Um, Medical equipment costs are going up, research costs, pharmaceuticals costs are going up. Now, smaller places, we will not have the negotiating power as, say, bigger systems. Now, with costs going up and reimbursement going down, the margins are already extremely tight. And then there's the external things of what happened, of what's coming down from CMS or from administration, just the changes in the landscape. So that's on the leadership side. That's the biggest challenge, I would say. The uncertainty that's coming, costs rising, reimbursement going down. But then there's a reality that as new technology comes out, education for our residents and for our medical students, they're trained on those things. Um, and so if a system can't afford the new technologies, well, the doctors that are being trained on, let's say, a Da Vinci robot may not have that Da Vinci in a rural hospital. If they're trained on AI and the hospital setting doesn't have AI, then our workforce is going to be a very particular workforce, right? You can't pick up somebody straight out of residency because they have to have a certain amount of experience. At the same time, I have physicians that have been practicing here for 40 years, right? They're looking at that, they're looking to retire. So I have an aging workforce. I have a young workforce that's going to be coming in that's not necessarily trained in a rural setting. So these are all the things that keep me up at night.
And it's interesting, you mentioned the cost of AI, and obviously any new technology has costs associated with it. But I think there's a lot of evidence that shows that there's really positive ROIs that are associated. So if you can afford that upfront investment, there's a positive ROI that you can achieve down the line. Do you guys believe that? And is there any particular technology in particular that you think can sort of achieve this goal?
Oh, absolutely. And I think that's where yeah, working with Commure, you guys are actually really helping us. One thing, so the with the CMIO hat, I anticipate that I mean, healthcare is such a complex thing. When it comes to rev cycle, when it comes to documentation, when it comes to regulation, when it comes to all of these things. And the way that I see it is if we're if we're in the early adopter phase, if we can help kind of if we're able to work with, let's say, Commure or AI companies and become proofs of concept, that's perfect, right? Now, for me, I see AI helping us with workflows from the time that you see the patient till the time that you're having to deal with reimbursement, right? So, the doctor interacting with the patient, AI scribes, AI documentation. Absolutely. The doctor just trying to find information in siloed systems, right? So we have an old EMR, we have a new EMR, we have an outpatient EMR, we have a nursing home. It's all siloed out, right? When you're doing GI scopes, that's in Provation. So putting it all in a data lake, having the AI helping you to search and summarize, right? Like that's huge for us. If they go to another care site, if they go to another hospital, or we're transferring to a tertiary site, how do we communicate our information with them? AI can actually help us, with that. When it comes to coding, like I never went to med school for coding, right? Or billing, right? So the AI can actually create the problem list, help us with find the right code, and then making sure that it can um, get reimbursed dealing with the AI that the insurance companies are using, right? So there's so much. I use AI a lot for education. So when it comes to training new doctors on how to use AI or sepsis guidelines or antibiotic stewardship, I actually use different AIs to help me not only create the content, but create video of me so I'm not having to keep re-recording myself. So if we, so the ROI that you talk about, absolutely. If we lean into it and learn about it and educate to it, then we'll be ahead of the curve rather than 5 years from now when we're going to be, we won't be relevant enough to even catch up on that learning curve. Does that make sense?
Absolutely. And also I think you describe what I would call almost like a leveling of the playing field phenomenon. So again, when you're a rural hospital and you're under resourced compared to, let's say, a large academic medical center, you don't have like even the people resources, right? I imagine that hiring coders and billers is a very difficult thing to do. Hiring scribes is probably a difficult thing to do. So I think that in many ways, the technology has this leveling effect, which I think is really cool from an administrative standpoint. And then for somebody who remembers, the when we used to get up to date on a CD-ROM, right? Remember, you get up to date on a CD-ROM, you push it into the computer. I think that with the advent of these co-pilots and these other types of systems that allow you to access information about standard of care, about new research, and deliver that information to you right in line as you're providing care to the patient, I think there is a real leveling phenomenon. Because again, I think in rural environments, maybe because you're not as attractive to many recent trainees. Maybe you're not getting all of the modern information or the up-to-date information. But with the AI, you can literally ask a question about like, what is the current standard of care for diabetes management, or what's the standard of care for any other clinical indication that I'm interested in. So does that ring a bell? Sort of this notion of leveling?
Oh, absolutely. And that's exactly where my mind space has been, my headspace on how do we catch up if we can't, if we don't have the resources, right? So there is definitely a resource gap. Like and you had mentioned hiring coders. Coders, we would need a lot of coders to keep up with our data. Um Not only that, what about a call center? So we are actually looking into agentic AI to help us create a call center. When it comes to information, you were spot on. Up to date used to be the CD, right? Now up to date's got their expert AI, and so that really helps us to 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 stay relevant and to keep up with the care. But honestly, what so why am I doing this? We're just trying to help these people out, right? Like there's a lot of people in rural America that needs help, and how do we make sure that they still get the care? Because if it takes them an hour to get to us, it takes them 4 hours to get anywhere else. And so just to be kind of the tip of the spear for them to help them out, that is so big. And so absolutely, AI, the way I see it, will help us kind of catch up. Um, Now it's funny because I talk to a lot of colleagues and like, hey, aren't you worried that AI is going to replace you? And I'm like, no, actually, I think right now what will replace me is a doctor that knows how to use AI if I don't know how to use it, right? So for clinicians that embrace AI, that lean into it, they're the ones that are are going to become relevant later. And it's kind of I remember when we did the transition from paper to an electronic medical record, those docs that weren't able to make that transition, they retired. Because they couldn't keep up with the regulation, with the care. And I see a similar thing happening with AI. Now, in our care setting, where we did a mistake is when rolling out an EMR, the docs weren't really a part of the build, right? Or even creating an EMR, right? Docs haven't always been a part of the build. With AI, though, I'm seeing a very distinct difference where doctors, clinicians are being asked um, to be a part of the build because that's how they develop an AI that actually makes sense, right? And so that's where I'm actually very hopeful that this AI transformation is going to be big, as long as we're a part of being at the table.
Interesting. And it's very funny. I have a son who I had to take to the emergency room because he presented with what looked like an acute abdomen. Turns out that he didn't have appendicitis. He had some kind of acute gastroenteritis that looked like appendicitis. And it's funny, when I go into a healthcare setting, I always tell people that I'm a doctor. I find that I get better service, or at least my perception is that I get better service. But I also explain to them that I work at Commure and I work at an AI company. And both the doctor and the nurse who I engage with, like literally the first thing that they said is like, is this technology going to replace me? And I said, like, can that technology put in an IV? Can that technology, do a physical exam? Probably not, and not probably for a while. So it's interesting to get provider perspective, but I think it does raise a good question, and really a question that gets at the heart of this podcast, which is, in a world where now you have AI that literally has the answers at your fingertips, right? Like the AI can take, a lab report and come up with an interpretation, which is, as you know, something that we spend years learning how to do, right? If the technology can look at a blood gas and basically tell you that this is a metabolic acidosis much more quickly and much more reliably than you can as a doctor, a big question that I have is like, what does it mean to be a provider of any kind, but a doctor in particular? What does that mean? What does it mean when we have all these technologies at our fingertips? And how will our practice change? How will the profession change? What will we do differently in the future? So I'd love to get your perspective on that.
Yeah, I think that's actually a great question. So because there's a lot of different, I would say there's a lot of different things that are happening all at once for doctors specifically, meaning there's telemedicine. So now a doc doesn't necessarily have to be in person to see a patient and take care of them, right? There's remote monitoring, right? There's digital stethoscopes. Then there's, of course, nurse practitioners and PAs and how they're kind of coming into the mix, right? Um, and then there's with AI, with what we have at our fingertips, because you were spot on about the being able to, take in the information, process it quickly, and present it to the doc, to present it to the clinician in a way that makes sense. But it's still up to the doctor who has, let's say, had that lawsuit or had that patient where they followed the book, if you will, and they got it wrong. I think if I had to grade the AI right now, I would say they're like a first year medical student, right? They're taking in a lot of information, but the art that comes with practicing, that still takes time. Now, I think in the future, as we are training the AI, we have to train it with our mistakes, right? We have to train it with our lawsuits, basically, our malpractice claims. We have to train it with culture, right? We have to make sure that um, that if a patient is speaking a certain way, that it can pick up the cultural nuances between languages, right? Like, there's a lot of different things where I see doctors becoming essentially the stewards of it, and a doc that again can help train it and build it is going to be huge for us. Or else there's going to be major mistakes that are going to happen, and ultimately, what happens in medical care here? Well, there's going to be a lawsuit if we don't do it right. And why? Because somebody is going to have a biased care that they didn't think about this or they didn't think about that. And that's where I worry about the AI.
I think that's very interesting. And you hit upon a couple points. So, first, I think people underestimate the potential benefit, med mal benefit from the technology, right? Because again, so much, it, if you've ever looked at a med mal claim, like so many of them are just due to not like intentional negligence. Somebody was being dumb. They like literally just missed a little thing, and then that turns into a malpractice suit down the line. So I do think that a lot people worry about these AI technologies hallucinating in a clinical environment, and that may happen. But I think the human kind of fallibility happens 100 times more often. And if we have technology backing us up, I think that that's going to make a big difference and really help from a med mal. So I think a lot of people don't think about that all too much. I think another thing that you frame that you used was this notion that the technology is like a first year medical student, I think you said. And it'll be interesting as the technology becomes like a third year medical student. So you remember like how much more competent you are once you go from first year to third year med school. And then when you become an intern, you're even more competent. And then your third year resident, you're more competent. And it's interesting because like, I'm sure, you've had that experience as you've been responsible for a clinical team. Like if you're surrounded by a whole bunch of interns, you're like, oh my God, I have to think about all these things because the interns, the interns or the first year medical students they don't understand these things. But if you have a team of really competent clinicians around you and you're not worried that you're missing things or that you're misinterpreting things, all of a sudden now you get to focus on a much higher order level of concerns, right? And maybe you start thinking about the economic aspects, like, okay, how do we reduce the overall cost of care as opposed to how do we make sure that we, exactly executed on this clinical protocol? And I think what it allows you to do is sort of turn your aperture up and out and to be more focused on the other ways that you can create value. And that whole concept of AI as interns. I think Vinod Khosla, who is a very famous venture capitalist, has used that concept. Like the technology is like having a whole bunch of interns. And then as the technology gets better, you get more and more support for providers to do, I think, higher and higher level work.
Oh no, absolutely. And I think it's interesting to see AI use in medical schools versus residencies. I think so my background, so I was an engineer, and I remember at Rutgers we had to first code a calculator using Fortran before we could actually use the calculator, right? So it's almost like you have to I do see medical training having to have some education on how AIs are built or how LLMs are built or what or how an agentic does. Like there's going to have to be some kind of training for I think medical students where they're not only learning about biochemistry or pathology, right? There's going to have to be, because it's going to be so integrated in our systems later. Another interesting thing I've noticed, especially when it comes to surgical care, we are using, let's say, Da Vinci robots or all these different things. Nowadays, a doc can be on one side of the country performing surgery on the other side of the country. Now, if there's an AI that's learning on how to do those procedures after a while, doing a lap appy, doing a lap chole, I do see this happening. But again, it's like you said, it brings the doctor to a whole other level as long as they're using their tools effectively. So that's where there's definitely going to be a transformation, and I think for docs getting ahead of the curve, learning about it, that it's going to be better.
Yeah.
So yeah.
So you mentioned Rutgers. So I'm also from the great state of New Jersey. So I grew up in New Jersey. So go Rutgers. Um, and you know, I'll tell you, I have a bunch of friends who are still involved in academic medicine, and what they say is like there's not a lot of education around AI happening right now. There's still a very much a focus on the basics, anatomy, biochemistry, physiology, etc. But I will say to the defense of the medical students and the residents, I think a lot of them are not waiting, right? A lot of them are like, wow, this is all I hear about, and how can I make my studying more effective for the medical students, right? How can I use AI to learn all this material more quickly? And for the medical residents, like how can I use the AI so I can get out of the hospital sooner and go home and see my wife and see my kids or get some sleep or take a bath? And so I think there's some agency that the med students and the residents have, and hopefully they can drag their training programs along with them.
No, absolutely. And it's again, yeah, I have a couple of cousins that are going through the medical school process, and one of the medical schools actually completely took away all AI. They first piloted it, and now they've taken it away, saying, "Okay, once you get to this level, then we'll." It's interesting though, because we're trying to figure this out. This is change, right? And um, again, for me, another big thing that I'm trying to do, because primarily we've been thinking about how AI is going to influence the doctors, the APPs. For me, I'm trying to figure out how to get my nurses to start using AI because their documentation, I thought our documentation was bad. Oh wow. And their nurses spend so much more time in front of a patient. So, how can we actually distill the documentation so that nurse can really just take care of that patient? It's and so I do have hope that AI is going to simplify a lot of the processes and the workflows that we have. Because again, like, we were talking about med mal before. Usually, med mal happens because of a broken process. It's usually not the person, right? Usually, I would say 95% of the time it's a process breakdown. And I see AI helping that. And so again, very hopeful. But that's where, the opportunity that you and Commure is giving us is huge. Because again, we wouldn't have had this as a rural setting. And so again, and this isn't for the podcast. This is just being genuine and thanking you, and your team, just, helping us to not only come to the 20th century, but moving past that.
For sure, for sure. And look, I think, what I always say is that if you go into a typical hospital, and especially a community hospital, um, you'll see, I mean, it's just a very inefficiently run organization with a lot of paper. And, if you were to compare a hospital to your bank, or if you were to compare a hospital to any other kind of entity, and obviously what we do in medicine is maybe a little different, we're just very, very inefficient. So while it is great that we're using ambient technology for physicians and mid-levels, there's a whole other group of people who we can empower, right? So again, you're talking about nurses, the MAs, the respiratory therapists, basically everybody who's patient facing certainly can be empowered with this technology. And then I think what we dump into the category of admin, right, from everything as it relates to revenue cycle management, but all the other areas of the hospital where people uh, have to manage a series of processes, to be able to do that with technology and to do it more efficiently, I think again allows us to deliver better care, have better financial performance, and keep these hospitals alive that are really on the brink now. So maybe, as we get to the end here, I mean, talk to me a little bit about, the potential Medicaid cuts and what does that mean to a rural hospital, and maybe where does AI fit in terms of helping you there?
No, absolutely. I mean, it's always hard to know how a change is going to affect us until we go through it, right? With Medicaid and Medicare cuts, what I see happening, if a patient needs help, they're going to still come to the ER, right? That patient may have been helped sooner if they were able to make it to their primary care doctor or their specialist. But if they're afraid because they can't pay for it, again, our systems, we have ways to get charity care. We have ways to help that patient that doesn't have insurance. I think ultimately, I worry about a lot of that care just going into the emergency room, and that it's already so far gone, meaning had an intervention happened earlier, their care would have been a lot easier to deal with, right? So, for instance, a patient with cancer, um, because they weren't able to get into the care because they didn't have insurance, that cancer now metastasizes and starts causing blood clots and heart failure. And that's like that'll be when when the patient comes in. So now this is a person that we could have helped, but because of insurance or just feeling afraid of going to seek care because how expensive it is, um, that's what I worry about. So I worry about people's acute illnesses just taking over, people coming in too late, and and of course us being a safety net, we're going to do whatever we can, and then after a while it's, well, it becomes a tougher conversation, and so that's where I guess that's where my mind goes to initially when I hear about cuts in Medicare, Medicaid, things like that. I think what is important is ultimately a hospital, if a patient comes to a hospital or a clinical care site, we're going to help. That's why we're in this, right? How our institutions pay for it, that's something that has always been an afterthought, really. And you hear about Medicare for all, you hear about private, like you hear about all these things. In the end, when an ER doc, when a family medicine doc, when a provider is seeing somebody at the urgent care, they're going to just take care of the patient in front of them. They're not asking about, hey, do you have Medicaid? Do you have Medicare? What, right? We're just going to do the care, and most of the care will be charity care. That's what I see happening in a rural setting. Um, Ultimately, what also I do foresee happening is those hospitals that really rely on Medicare or Medicaid, if they're not getting that funding, with margins becoming difficult for hospitals and ERs, that's not being compensated for, after a while they close down. And that's the sad part, right? As hospital, and we're seeing this in rural settings, right? How many rural hospitals have closed down because of poor processes or margins or just loss, right? Now, whether a company or an insurance company or private equity or another hospital purchases that is a different story. For the most part, if it's a bad investment, they just won't. And so now you just have a huge region that where patients are just not getting the care. So that's again, it's hard to know where this will go. But for us, we're rural, we're nonprofit, we're independent, we're going to do the best that we can. Um, and, uh, and hopefully, people that kind of have that in their mission come to help us out.
Yeah. And as a follow-up to that, I mean, have you started to make any adjustments to proposed, or are you guys already starting to change the way you operate in anticipation of these cuts? Has that changed the organization at all?
So it has. I mean, obviously, strategizing for our future is always an important thing, right? And so AI is a part of that. So we're figuring, hey, if we get into AI now, that may actually help us to be more efficient. It may actually help us to get reimbursed because we're getting the prior auths done correctly. It's helping our processes. So that's where AI is a major strategy for us to actually get ahead of the curve, right? Obviously, in order to run a business, you have to look at waste, you have to look at um, what service lines are actually lucrative versus not, right? And so we're trying to keep all of our services up and running, at the same time giving more support to those service lines that are actually helping our bottom line is going to be important. There is a reality to that. And but again, AI and remote monitoring, you truly leveraging technology to help us be faster, be better, be smarter, is going to be big. Like one thing that we do have a nursing home, for instance, and remote monitoring, where you have like a sensor on the wall which can kind of capture your vitals and this and that. We're looking into that, right? We're looking to see how can we use technology to help us be faster and better. And we're hoping that whatever cuts come our way, that we're too strong to have it affect us, right? So that's the hope.
Sounds good. And I continue to believe that a lot of these technologies make more sense in a value-based care environment, right? So, those sensors, when you're trying to operate in a fee-for-service world, and you're like, how am I billing for this? The value is questionable. But I think in a world where those sensors allow you to identify that patient who has got a medical issue, a medical complication, and allows you to operate in a way that reduces costs, right? Prevents an ER admission. I think that is very exciting. And I think that RPM, remote patient monitoring, is going to be a big application, in the remote setting, especially when people are separated by hours and hundreds of miles potentially. All right. So, just some last thoughts here. Just, you have been, very forward thinking. The reason I wanted you to participate in this podcast is because I enjoyed speaking with you so much. And I thought you had some great ideas when we spoke. So, what can you share with other, let's say, rural health providers who are sitting in your shoes, and whether they're in upstate New York, which can be as rural as any other place in the country, or if they're in Iowa, Nebraska, or Idaho, like what thoughts or what framework would you encourage them to adopt as they think about AI?
So yeah, no, I think leaning into it is important, right? I think first getting first understanding it, learning it, getting the governance structure in early, including clinicians, nursing, everybody involved in that governance structure is going to be important. I think not outsourcing judgment to an algorithm is important, right? We have to actively shape. We have to actively shape how we're going to use AI, and I think partnering early with companies, or partnering early with those that are trying to get into the healthcare space is important, um, because rural systems can't afford to sit this out, right? Like we can't afford, because time is against us. If we get in early, if we learn it early, and if we're thoughtful with adopting this, then we could still maintain that humanity in the center. And I think that's what's important. I think being proactive in this case is better than being reactive, which is, again, the opposite of acute medical care, right? We're always very reactive, putting out fires, rather than proactively thinking, how can we get ahead of this? So that's the advice that I would give to other CMOs, CMIOs in a rural space, to clinicians, to docs, to APPs. I would say get involved, learn, be at the table. I always kind of say this: if you're not at the table, you're on the menu. So be at the table while decisions are being made, because if workflows are being created without you being there, um, then the wrong workflow will be created.
I like it. And I like the idea of having all of the clinical stakeholders. I think, getting patients involved too is a really important one, right? And having them be part of this process and providing feedback and, helping you understand what their preferences are and what their needs are. I think also this idea of reaching out to other rural health providers who are in the same shoes that you're in and not necessarily reinventing the wheel. I think it's really useful to work with other people who are dealing with the same challenges, and you can learn from them and sort of shortcut the process of getting to your end state and where you want to be.
No, absolutely. And so that's where, as we're getting into next year and we're deploying all these things that we are doing with y'all, with our system, I want to be able to help other rural settings to be able to do this, because the problems that we're dealing with, other people are too. So how do we shorten that learning curve for them so they can get to that next state quicker?
Well, great. So what I wanted to do is first thank Dr. Devroy for joining us today on the Prescribing the Future podcast. I think we had a great discussion, and I'm glad you're able to join us and carve time out of your busy schedule. I see your white coat and your stethoscope on, so I know you're probably going to be running to see some patients after this. And I wanted to thank the audience for listening today, and I want to invite everybody to subscribe to our YouTube channel. We're going to be posting this podcast and all our other shows, and we have a series of podcasts that we have ongoing. And if you'd like any other future updates, you can check out our website at commure.com. So thanks again to everyone, and we look forward to seeing you in the next episode.